Good afternoon, everyone. So today I'm going to talk a little bit about the general principles of treating cataracts in eyes with uveitis. Uveitic cataracts come with two main challenges. One is to treat the underlying uveitis, and the second is obviously the unique surgical difficulties that come in tackling these challenging cases. And in my talk today, I'll be focusing on primarily the surgical challenges we face, so the latter. So this is how uveitic cataracts usually present to our clinic. The challenges start from the preoperative control of inflammation to various intraoperative problems like poor visibility because of the band-shaped keratopathy, small pupils, posterior synechiae, pupillary membranes, and of course abnormal anterior capsules. The postoperative course is also complicated by the presence of persistent postoperative inflammation, dense PCOs, and of course cystoid macular edema, and therefore a very thorough systemic and ocular examination is required in these cases in order to ensure that there's no other systemic pathology, and if it's there, it's well under control, and especially to look at the fundus and the posterior segment to make sure that has been examined as well. So from a surgical point of view, the most important thing is to ensure that the eye is quiet and free of inflammation before cataract surgery, and this cannot be stressed more. This is of paramount importance in order to ensure a good clinical outcome. This diffuse and slit lamp image on your left side shows an eye with an active disease. You can see this angry looking eye with corneal edema, shallow anterior chamber, and a boggy iris, and the presence of an active disease on this slit lamp image as well. These corresponding images are those of an inactive disease, and therefore the thumb rule, or the rule number one in performing surgery in these eyes, is of course to always wait till the eye is absolutely quiet before proceeding with any surgery. This applies to all cases except two important exceptions. One is when the cause of the inflammation is the lens itself, and in this situation the lens must be removed as soon as possible, but of course after initiating treatment. And the other is Fuchs heterochromic uveitis, where we don't wait too long either. So we'll jump into a few interesting cases. This was a 35-year-old gentleman with a quiet eye and a white cataract, and his B scan was normal. The eye was quiet at the time of surgery. The main challenge we anticipated were due to the patient's young age, a difficulty in achieving a good capsular rhexis and the possibility of posterior synechiae, which you can see here are being broken with a blunt spatula. We used two Kugelin hooks in opposite quadrants to stretch the pupil and achieve adequate dilatation. After making the tunnel, the viscoelastic was washed off, the capsule was stained, and blunt acetone was used to initiate the entry. But because of the intumescent lens, a decision to fill the eye with a cohesive viscoelastic and switch to microrhexis forceps was made to complete the capsular rhexis. An attempt was made to create a large capsular rhexis along the pupillary margin, and then phacoemulsification was completed as a routine in this soft cataract, followed by bimanual irrigation and aspiration. Viscoelastic was filled in the eye, and all attempts are made always in uveitic eyes to place the lens in the bag. The lens was pushed into place, dialed into place, and you can see that while the viscoelastic was being washed off, we could get an idea of the rhexis margin. The rhexis in this case appeared to be slightly smaller than what we would like for uveitic cataracts. This is because a slightly larger rhexis is required in these cataracts to prevent iridocapsular adhesions in the future, and therefore a decision to enlarge this rhexis at the end of the surgery with the IOL as a protection or a scaffold was made, and that was done. Wounds were hydrated and the eye was closed. This next patient was slightly older with a quiet eye but had a history of granulomatous uveitis. The main surgical concern for us was the poorly dilating rigid pupil and very hard brown cataract. Now a little bit of a note on the surgical PI which we make at the start of surgery. This is usually done, and this I've learned from Dr. Somshila, is that we usually do it at the start of the surgery when the pupil is taut under the stretch that is produced by the posterior synechiae and the presence of a membrane, and therefore making this at the beginning is actually more beneficial than making it at the end. Viscoelastic is frilled from the opposite side, and then a Sinskey hook can be used to break adhesions. However, one must be careful and be prepared for the possibility of bleeding at this time. So the Sinskey hook is used to break all these posterior synechiae, and then Kugelin's hooks are again used for mechanically stretch the pupil. They create small tears at the pupillary edge. However, this is necessary because good outcome, surgical outcome trumps cosmesis. And you can see that despite the stretching, the pupil is still quite small and may not be large enough to tackle this dense brown cataract. And in the presence of such a fibrotic small pupil, just stretching the pupil with Kuglin's hooks might be inadequate, and therefore what we decided to do was go ahead and make 4 more incisions to place iris hooks. Ideally 4 or even 5 iris hooks may be placed. So that's the first one. This is the second one going in. The third one and the fourth. We had already initiated a rhexis, but we realized while doing the rhexis that the size of the pupil might be inadequate, and therefore decided to go ahead and put 4 iris hooks. The rhexis is now completed with the help of rhexis forceps, and what we get is a nice round large rhexis. So once the rhexis is complete, phacoemulsification. So we decided to put in a 5th iris hook because we wanted to ensure that there was no iris chaffing in the subincisional area during phacoemulsification in this hard cataract. This is quite a hard, dense cataract, and therefore cataract surgery in these cases is similar to what we do with hard cataracts, respecting the hardness of the cataract. All efforts are made to ensure a safe surgery. IA was completed after the removal of iris hooks in this case, and after removal of all the iris hooks, IA was done, cortex was removed, and an intraocular lens was placed in the bag. Right. So this was an extremely challenging case involving a young girl with bilateral anterior uveitis. There were 360 degrees of posterior synechiae, and she had this dense taut membrane. In cases like these where there's full 360-degree synechiae, it's important to try finding a small spot where you can insert your Sinski and try to start separating the membrane. And while this step may be minor, there are these small nuances can affect the entire surgery, while as the iris tissue may bleed when manipulated during this step. And if you can't find a plane, it's useful to try using a 26 gauge needle to place between the iris and the lens. However, in this case, because the membrane was thick, intraocular scissors were used, and once a plane was found, this mechanical pupillary stretch was done. But you can see that even at the end of the stretch, the pupil is still quite small. So in such rigid pupils, using iris hooks is very useful as against B-hex or Malugan rings, which may not be very useful in such fibrotic pupils. Iris hooks are better because they allow targeted traction and pull the iris out in all 4 quadrants, producing an adequate dilatation. The capsular rhexis was started with a bent cystotome. However, this was a young patient, and therefore there was a risk of the rhexis running out. And therefore a decision to switch to rhexis forceps was made in order to complete the capsular rhexis more safely. Since this was a relatively soft cataract, phacoemulsification was completed quite easily and did not pose much of a challenge, and was completed quite easily. However, during INA you can see that there's a small capsular tear over here inferiorly, and therefore a decision to place a 3-piece lens as against a single-piece lens was made in the capsular bag, and the IOL is then dialed into position. So finally, at the end of the case, the iris hooks were removed, and it's useful to keep in mind that the tip of the hook should be placed parallel to the wound in order to prevent any damage to the side ports. Viscoelastic was removed, and the wounds were hydrated, and at the end of the surgery we gave an intravitreal steroid injection in order to help control the possible inflammation. So uveitic cataracts are never easy to deal with, but with patience, planning, and of course collaboration with our retina and uvea colleagues, it is possible to get gratifying outcomes in these challenging cases. Thank you so much.